right, everyone. According to my watch, it's 1800 Central European time sharp. Now I do see that some people are still joining the sessions. I would just like to kick things off and hand it over to James Burkhardt from DORC, who has been helping us with setting up this meeting, and who will then pass it on to Cecilia from EVRCnet, and James will give us a quick introduction about the organizational part of this session. So please, James.
Thank you very much, Kai. Thank you, and good evening and welcome, everybody. Yes, on behalf of DORC, we're delighted to be providing technical support for this event. And I'd just like to remind all of you as attendees that you're on mute, your camera is off, and we'd like to encourage you to use the chat function to raise questions. We really welcome questions throughout the session. And then also, please look out for the polls which will come out during the event. The polls are important to answer both for the speakers and also for the CME points, which are eligible as a live participant to this event. And then at the end of this event, there will also be a short series of 5 questions as a post-event evaluation, which is also required to complete for the eligibility to the CME points. So without further delay, I'd like to hand over to Cecilia Martino, who is CEO of the European Vision Institute, and who we're delighted to collaborate with for this event. So Cecilia, over to you.
Hello. So I hope I'm sharing my screen now.
Yep.
Yeah?
Yes.
Okay. Okay, great. So just a very quick overview of our network, and we're very pleased to support this initiative. So not taking too much time, but just to give you an idea. So EVICRnet, we are a network of 96 clinical research sites from 16 countries, European countries, and our coordinating center is located at IBLE in Portugal, Coimbra, sorry. Our chairman is Professor Henrik Scholl from Switzerland. Scientifically, the network is organized by expert committees, all dedicated to the different subspecialties in ophthalmology. And we also have 3 transversal sections. We have key opinion leaders, as you can see, as coordinators of these different expert committees and transversal sections. So the added value of our network is basically we have expertise in ophthalmology clinical research. We are dedicated to support multinational investigator-initiated studies or research. And we have a single contact point at our coordinating center, which is very useful as Europe can be a bit complex to approach. Also, we are a network of certified clinical sites, meaning that we have harmonized procedures that the centers follow when performing clinical research within our network. And we also have developed standard operating procedures for technical procedures in ophthalmology clinical research. We also develop training activities, and like this one today, and they are all available in our website. Just to quickly, how do we support multinational investigator-initiated studies, and what are really the big challenges for the investigators? This means that when we talk about multinational, Europe is quite a challenge, as that means that research has to go across the borders. And we're talking about different national legislations and specifications, different entities that need to be involved in each country, as well as different languages. Besides this, when we talk about investigator-initiated study, this means that the investigator assumes all the sponsor's responsibility, meaning that he does really need another partner to be involved with him, like EVICRnet, that can provide the overall management and logistical support for the investigator to carry out his multinational investigator study. This is just an overview of our educational program. Again, like I said, available at our website. The most recent model is dedicated to retinal dystrophies. It's for free. Anyone can just take advantage of it and just register and follow the procedures. And I just want to wish you a great meeting today. Thank you.
All right. Thanks, Cecilia.
Sure.
We'll just dive right into it, not before saying the adequate thanks, because it takes a lot of work putting together a seminar like this. So thanks to the team around James from DORC, to Cecilia, and especially to Danielle and everyone from EVCRNet who really put together such a great seminar. Also, thanks for all the speakers who were willing to attend, and also to my lovely panel, but this is only referred to you, Aude. I'd like to present Aude Codier from Paris. And of course, David Steele, you as well, the president of BEVA. There's no need to introduce the two of you. And I'd just like to hand it over to Dr. Aman Chandra, who's not also a very excellent vitreoretinal surgeon and an excellent person to have scientific discussions in the later hours. He's also a very versatile scientific researcher who just published a research paper on the impact of COVID-19 on retinal cases in Beijing. I think that was very interesting to read. And Aman will start off the evening with his first talk. Aman, thanks for being here, and I'm really excited and looking forward to hearing your presentation.
Thank you, Kai. And I'm going to just try and do this bit to share the screen. Is that good? Can you see my screen? All good. Well, thank you for that kind introduction, and particularly I want to thank DORC and EVICR for arranging this session. You've got some great speakers today talking about surgical liquid devices. My talk is aimed at surgeons, but some of it is really quite highbrow. My talk is more clinically based, and will hopefully give you my opinions and tips on stuff, and some of the discussions that might follow I hope will be useful. So I am Aman Chandra. I'm a retinal surgeon in Southend in the UK, and affiliation with our local medical school. Southend, just for you, those of you who aren't from the UK, is in a place called Essex, which is on the east of London there. It's the bit in red that's regarded as part of the east of England. So not far from London, but far enough. Anyway, I'll tuck straight into it now. So we're going to talk about silicone oils, light and heavy, and peripheral carbon liquids, the main liquid devices that we use in vitreoretinal surgery. I'm not going to talk about any of the dyes that we may use. One of the key components to the use of these surgical liquid devices is their density. If you look at that table on the right, water has a density about 1 gram per cubic centimeters, and anything with a lighter density, such as silicone oils and gases, tends to float above it, and anything with a lower one tends to sink below it. And those are the real practical key components that we rely on when using them surgically. So let's start with silicone oils. So silicone oils are siloxane-based compounds with methyl groups, mostly methyl groups, for the ones that we use in vitreoretinal surgery. They're hydrophobic, which is a key part of them. But they use either as short or long-term tamponades, tamponade being a substance that we leave in the eye. As that table previously showed, they have a lower specific gravity than aqueous, so therefore floats and provides an upward force. There's a picture of an eyeball there. So the force is the highest at that asterisk, and the force reduces towards the meniscus. So the greatest force and tamponading effect is at the apex of that bubble. They are oxygen-based linear polymers, and the silicone oils that we use, the physical properties that we depend on are the chain length. So in general, they come in 1, 2, and 5,000 millipascals or centistokes. And one of the other key components is their chain length distribution. So if you have a narrow distribution, so this graph on the bottom here, this is meant to illustrate the homogeneity of the product that we use. So a narrow distribution, such as this blue one, would be a more homogeneous oil with more defined properties. So if you have an oil such as this orange one at the bottom here, with a wide spectrum of chain lengths, then the properties of that substance you're using will be much more varied. So ideally, you want a narrower distribution of centerstokes. When do we use silicon oils? We use it in cases with proliferative vitreoretinopathy. We may use it in cases of altitude where patients may not be able to use gas. And in cases of proliferative retinopathy or other proliferative conditions, it keeps hemorrhage away. It may reduce anterior ischemia by reducing the migration of pro-inflammatory cytokines into the anterior segment. And if there are any breaks in the retina associated with membranes, we may use the silicon oil to keep that retina in place while those membranes mature and don't lift the break. And they may be used in trauma, sometimes as simply as a tamponade to keep the eye firm. So how do we use oils? So that's a run through of primarily the indications when you might use them. If you want to put oil in, you will either have an eye with oil with saline in it or perfluorocarbon liquid. And then on the left, you may then exchange that fluid for air and then exchange the air for oil. Or on the right, you may change the perfluorocarbon liquid particularly directly for oil. So if you're exchanging air for oil, this is a diagram of a left eye. You can see my artistic skills are quite remarkable. You've got 3 ports here. I tend to reduce the infusion to about 10 millimeters of mercury, then start injecting my oil and remove a valve or make sure that there's a place for the air that's in the eye to escape whilst the oil is being injected. So here's a video of an eye, the same eye, a little bit less beautifully done as my art was. On the left, top left, you'll see the infusion line. And on the this one here is the spare trocar, and here is oil being injected in. So I'll take the valve off this port and you can see the bubbles of air escaping. And eventually when the oil is, when the eye is getting more filled with oil, you may see the oil elevating through the infusion line, and you've got a more confidence that the eye is now full of oil. So that's how you exchange air for oil. Sometimes people may exchange perfluorocarbon liquids directly for oil. Here I've got a couple of videos of it. Here's on the left, perfluorocarbon liquid being injected into an eye with a retinectomy to flatten the retina. And then subsequently, silicon oil being injected directly into the eye. So here we stop there. On the left, you'll see a light pipe. On the right, that's an extrusion cannula. On the top left, that's the oil being held in place. You see the oil coming in now from the left. And you may be able to see at the bottom here, the bubble of perfluorocarbon liquid being aspirated whilst the oil is being injected. Now that's my camera. On the right, I've got a video from Paul Sullivan, who's clearly got better videoing equipment than I have. That's perfluorocarbon liquid again being injected into an eye. And then you can see the cannula being placed into the perfluorocarbon liquid. Perfluorocarbon liquid will sink below the oil because it's got a higher density. How about removing oil? I usually do it with a 3-pass partner approach. With the infusion on, I remove the oil and do some air exchanges to remove most of the oil bubbles. Here is removal of oil with a 19-gauge cannula. This is not how I do it much now. Once the oil has been removed in its almost entirety, I'll turn the air on to allow it to wash any remnants of oil that may be stuck to the zonules and the anterior segment onto the surface of the water. So I ride the wave down, as I call it, I tell my fellows, and then turn the infusion on and ride the wave up again. That video is a bit dark, isn't it? I think it gets brighter. Yeah. So I ride the wave up again, and then I can repeat that process to a number of washes, put the air on again, and ride. So if you keep your cannula at the interface of the fluid and the air, that's where the silicon oil is likely to sit. I'll move on to heavy oils. Heavy oils are semi-fluorinated alkanes. Denseron has F6H8 and 5000 oil, and Oxane, which is another commercially available one, has RMN3 and 5700 oil, centerstoke oil. it's almost universally used solely for inferior pathology. So if I could do a poll now at this stage, I can't remember who the technical. Oh, here we are. So if you could tell me what you think. So when you're faced with an inferior PVR detachment, with a break inferiorly with PVR associated it, and you're deciding to do pars ponderofracectomy, do you as a surgeon most frequently use light silicone oil, heavy silicone oil, gas of your choice, or a combination of those oils with a buckle? So I think we're going to leave that for a moment on there. So this is in the context of inferior pathology, and this is really the only time you probably use heavy oil. I'm going to remove that poll from my screen, and I will continue in a moment. I think that's probably enough time, is it not, for the poll? Do we get the results now, or should we? Oh, here we are. Right, so it's pretty evenly spread. A lot of folk would use a buckle with oil. I think that's easy, and then an equal number would just use oil, and probably about half those using oil on their own would use light oil or heavy oil. So I think there's sometimes a bit of concern about heavy oil in terms of its inflammation, and maybe its effect on intraocular pressure. So this is unpublished data that we're still preparing for publication. We reviewed 134 eyes who had Denson 68 across a number of centres in the UK, and unsurprisingly, the vast majority of the indications were inferior PVR. And the median duration of the tamponade with Denson oil was 4 months, and there was a final reattachment rate of about 72%. Bear in mind, these are challenging cases. This can be an encouraging result. What people are worried about with heavy oils is long-term anterior uveitis. Well, that represented 6% of the cases. Long-term intraocular hypertension was 17%. Only 4 cases required surgical intervention for long-term intraocular hypertension. And emulsification occurred in about 4.5%. And none of these side effects had any correlation with the length of time that the Denson was in the eye. Now, these figures probably, we think, compare favorably to all silicone oils in terms of their side effect profile. So, we're encouraged that, some of the press that heavy oils may have may not be entirely justified. The key difference or the challenge with removing silicone oil, heavy silicone oil, is it's got a higher density than the aqueous and so sinks. What you've got to be careful of is when removing the oil is to keep that cannula in the bubble. And if you lose the bubble, like you're about to here, the eye becomes hypotenuse because you've got a high aspiration rate, high vacuum, and then that heavy bubble drops to the posterior segment. And then you've got a large bubble of silicone oil, which is highly viscous, difficult to remove, sitting on the posterior segment. So this is, one of the challenges of removing heavy oil. So the key thing is to keep that bubble on your cannula. So here we have the cannula with the VFC extrusion on it, and with direct visualization, keeping that cannula within the bubble. And it's key. It's important to move that cannula around to ensure that it stays within your bubble of heavy oil. And then you have a nice extraction of the heavy oil with no problems. Right, so I've talked about heavy oils and silicone oils. I'm going to move on to perfluorocarbon liquids. I'm mindful of my time. These are fully fluorinated carbon liquids. They can be either 8 carbon liquids or 10 with 18 fluoride atoms surrounding them. The key component of them, they are high density, so they sink, and low viscosity, and therefore actually quite easy to inject and extract. And they're hydrophobic, and therefore that means they're immiscible in water and blood. And their invention has been critical to many surgical procedures. They're often used intraoperatively to flatten retinas, for me, just in retinectomies or giant retinal tears. They can aid for vitreous trim because you can flatten the retina in a very mobile retina to allow the vitreous to be trimmed. And if you want to peel any membranes in a detached retina, they can help stabilize the retina. And they can be used as a short-term tamponade if needed. Here's a giant retinal tear, which is a sort of taco folded over. The edge of the giant retinal tear is then marked, and you can then use the peripheral carbon liquid, putting the cannula just in that gap to create space. And then you'll see now that it does create the space, and it helps to flip over that giant retinal tear, that detached retina, and roll it into its correct position. Keeping the cannula within the bubble, it allows us to use this as a device with a physical property that allowing you to flatten the retina. Some people use this in all retinal detachments, but it certainly has a role in giant retinal tear detachments. It can aid the peripheral trim. So here we have a sickle cell retinal detachment with a very mobile retina, and a bit of PVR there. And actually trying to trim the retina was challenging because the retina was so mobile. If you inject peripheral carbon liquid onto the posterior segment, that can help stabilize the retina, and then allows trimming of the peripheral vitreous to be much more easily undertaken. Very helpful, I think, in very mobile retinas. How about peeling and detached retina? Well, if you, for example, this is a case with a macular hole detachment where the retina was mobile, and you can see when the retina was mobile, it's very difficult to pick up the ILM because of lack of countertraction. And even if you do get a little flap, it can be difficult to peel because everything's mobile. If you then flatten at least the macula, you get some countertraction, and then peeling the ILM is much easier now because your retina is stabilized by the peripheral carbon liquid. And postoperatively, you can see the hole was closed. Here's just another example of that. This is a detached retina that required a retinectomy. And then it was apparent that there was PVR on the macula, which was difficult to peel because the retina was so mobile. Again, you can use perfluorooctane to flatten the retina. And then peeling this membrane off the macula is much easier when the retina is stabilized by your surgical liquid device, the peripheral carbon liquid. How about a short-term tamponade? Well, giant retinal tears is really one of the only indications for use as a short-term tamponade, and there's plenty of multiple papers now that demonstrate the safety and efficacy of using peripheral carbon liquid as a short-term tamponade, particularly in inferior giant retinal tears. I think you've seen this GRT already. This was the inferior GRT that was macular sparing. Peripheral carbon liquid is filled up, retinopexy is completed, and this operation is now finished. You can take the ports out and suture the sclerotomies, come back within 2 weeks. And it's very easy. The low viscosity of peripheral carbon liquid makes it very easy to remove. And then you'll see that you can examine the retina and see that the GRT has now been secured and the retinopexy has been completed. Very useful for inferior GRTs. You must be mindful that, however, leaving it in the eye for up to 2 weeks is quite inflammatory. You can get these macrophages on the lens. This is 10 days post-operatively. So if I do this, I give them quite an intensive course of anti-inflammatories. So we've talked about silicone oils. I've talked about exchanging it for air and for peripheral carbon liquid. Talked about removing it with multiple layer exchanges and removing of heavy oils and the challenges of doing that. With peripheral carbon liquids, we talk about how it's used to flatten the retina. It can be used to help remove the vitreous, peeling in detached retina, and I briefly talked about its role as a short-term tamponade. Thank you all for listening, and we can discuss this or any topics that I may have highlighted now. I think I've stopped sharing now. Can you see me?
Yep, yeah, we can see you, Aman. Thank you very much. That was a great talk, Aman. Lots of top tips and pearls of using these liquids. There's a couple of questions from the audience, and I'll just pick up on one and expand upon it.
Okay, thanks.
So the question was, which cannula do you use to insert PFCLs? And then secondarily and linked to that, could you give us some tips to avoid bubble formation when you inject PFCLs?
Yeah, so a dual bore cannula is ideal, where it allows some exiting from the size of the cannula. I don't always use that, so you have to inject very slowly. When injecting, I always recommend injecting away from the macula and the disc, because actually the jet has such a high force that it can actually pierce the retina. With regard to the bubbles, once you start getting a small bubble of PFCL, if you then insert the cannula into that bubble, it will be very close to the retina, so be mindful of that. And then inject slowly within the bubble, then you'll hopefully reduce the risk of getting small bubbles. Beginning with that, before you put the cannula in, I try and make sure that you go directly to where you know the retina isn't folded over. So you try and avoid any drips of peripheral carbon liquid coming off the cannula and slipping under the retina.
Which and do you put the PFCL in yourself, or do you use a VFC, or do you use?
I just do it myself with my index finger on a syringe.
Yeah, and do you alter the infusion pressure at all before you do it, or do you just keep?
So I reduce the pressure I start usually at 30. That's where my normal pressure is. So I reduce the pressure down to 20 as I inject.
And so another question that came up was the use of oil in endophthalmitis, Aman, and which is, and I was kind of when the question came up, I was also thinking about you know, the inflammation you showed with PFCLs and so on. Do you think oil's got a role in modulating endophthalmitis cases anymore, or do you use it purely on surgical indications with endophthalmitis? What are your views on that?
Yeah, that's a really good question, actually, because I didn't describe that indication. So when doing vitrectomy for endophthalmitis, I tend to have a very low threshold for using silicone oils, actually. I think there's a bactericidal effect of the silicone oils, but also endophthalmitis vitrectomy, it can be a very difficult view. You may not have induced a PVD thoroughly because you can't. You may not see if you've induced a break because of all the debris and all the challenges of doing the surgery. And they may be phakic and the lens may be difficult. So there's enough challenges for doing the surgery that will limit or increase the risk of complication. For me, then I have therefore a low threshold for putting silicone oil in. A, for its antibacterial potential effect, and B, also that if there is a break, hopefully it may help keep the retina in place. While that break sort of pigments and scars down. I think people worry then having to come back to do a second operation to remove the oil. I always say, if you're coming back to remove the silicone oil in an endophthalmitis case, you've won. You know, that means you've got visual potential and you've saved the eye. Vitrectomy for endophthalmitis, you've got sick eyes that may well end up being enucleated, and particularly if they've got streptococcus, over 50% of those will end up being enucleated. So if you're coming back to remove silicone oil, you save the eye. You know, it's not a big problem.
No, that's good. That's very true. I completely agree. Now we're running slightly short of time, so I wanted to finish on a question which is going to lead into Mario's talk, hopefully. So oil PFCL exchanges, of course, are contraindicated in terms of manufacturers' instructions, at least from you know. So most PFCL manufacturers say don't do direct oil PFCL exchanges. Yeah. What are your views on that? And do you think that's important in terms of avoiding toxicity?
Well, so I don't do it very often at all. I will always exchange it for a PFCL for air, followed by the oil. They do it. They're very similar substances. They will stick together very, very closely at the expense of any aqueous, despite what you might think in terms of its density. You might expect there to be a nice sandwich of saline in between them, but they don't. They stick together very closely. I think, you know, I'll leave it to Mario to talk about toxicity of the oils, but there is some concern that these two substances coming into close contact may increase the chance of toxicity of one of those substances and reduce the chance of removing the PFCL completely. So I personally try. I don't use it very often. There are obviously circumstances where I'm so concerned about contraction of the retina that you know, intraoperatively, that I feel I have no choice, but those are rare circumstances. Do you do it much, David, yourself?
No, I'm completely like you, man. I try to avoid it. I can't remember the last time I done it, apart from the fact I find it irksome and slow, but also there's so many evolving techniques to get rid of aqueous from PFCL eyes so you avoid slippage. So I just don't think there's a need to do it. Obviously, there'll always be exceptions, but yeah, so I agree.
Certainly in giant retinal tears, which is the main cause of slippage, because in retinectomies, you can certainly exchange it for air. You don't need to go to oil directly because the retinectomy edge is so far from the ciliary body, you don't get that pooling of aqueous. GRTs people are concerned about because they're so anterior, you get aqueous quickly accumulating. But I rarely use silicone oil in GRTs, and I think that, you know, macular ons particularly, I don't think there's a need for silicone oil in GRTs.
Yeah, and of course, you published a very nice paper on this showing the very high incidence of silicon-related visual loss in macular on GRTs. I mean, yes. We are mindful of time because we're slightly over, so I'm gonna go start on Mario's talk now. And now Mario is professor of ophthalmology in Milan, and also does his clinical practice in Bergamo near Milan. Mario's published extensively on toxicity considerations with oils and PFCLs. Several, if you haven't read them, I'd recommend you read his papers because they're fantastic papers, and we're delighted to have Mario speaking on this topic at the talk tonight. So thank you, Mario. Thank you.
Thank you so much. Thank you, David. Thank you so much for the kind invitation. So today I will speak about the purity and toxicity consideration for oils and for my conflict of interest. So we routinely use liquid as a surgical device, but what are our concerns while using liquid device? We believe that ours are still underestimated because we have lack of information about composition of some medical devices, lack of information on some chemical and biological interaction between intraocular devices, and also we don't know much about the correlation between medical device and acute and chronic clinical findings. This picture still occurs. So we believe that these clinical findings don't come only from the disease, but probably from a synergistic effect between different causes. So the aim of my presentation is to explore the value of the purity and the potential toxicity of both silicone oil and perfluorocarbon liquid, and also to assess the potential toxicity coming from their interaction. Let's start with silicone oil. We know that silicone oil in the market is not cytotoxic. Most of them have cell viability more than 70%. But still, our concern are on the low molecular weights component. So, because European chemical agencies since June 2018 have included the low molecular weights component in the candidate list of substances of very high concern, especially D4, D5, and D6. So what we did, we published a couple of papers looking at the assessment of low molecular weights component. First of all, the presence in silicone oil, and then the toxicity of low molecular weights component. We need to remember that during the polymerization reaction to generate silicone oil, we also get some impurities. Are not really impurities, just matter of dimension of molecules. So oligosiloxane. And what we did, we just compared the molecular weight distribution between 10 different brands of 1,000 centistock silicone oil. And we looked at the, under the tail of the curve on the left, the short chain components between 200 and 300 gram mole. And what we found, there is a huge difference between the different compounds on the market. And Joaquin will speak much better on this topic because he published a paper regarding benchmarking of silicone oil. But he said that the quality characteristic vary significantly not only among different brands, but also among batches. Then we also look to the toxicity of low molecular weights component. So we know that the concentration is different in different brands, but low molecular weights components are cytotoxic or not. So we analyzed the silicone oil with different concentration of low molecular weights component. At the end, all silicone oils were not cytotoxic. Bit difference about cell viability, but we are just speaking about acute toxicity. So we are not speaking about chronic potential damage. So we assess the acute cytotoxicity with our test, not any potential harmful effect. We need to remember that the low molecular weight component act as surfactants, so they can change the interfacial tension using emulsion, and they can also diffuse in ocular tissue, so they may accumulate in the environment and the tissue and cause effects that are unpredictable in long term. And they've been published already that we can see emulsion in epiretinal membrane, intraretinally, subretinally. So really we need to keep in account that in long term we can have damage, not just a matter of silicone oil of acute toxicity. So we still prefer product with the low concentration, low molecular weight component. What about the perfluorocarbon liquid? We know that this paper published in 2017 by Pasteur found that 120 cases after use of perfluoroctane had pale optic nerve, no light perception, retinal necrosis, and disruption of all retinal layers. We all know the history about the product coming from Alamedics, because he said that the product was not cytotoxic, but Yoba Pasteur did the analysis and found that the product was cytotoxic using a different method of analysis. Basically, the Alamedics chose the wrong testing method, so extract test, whereas using the test under the use of perfluorocarbon liquid, so direct contact test, Yoba found that it was cytotoxic. So, and since there, we had a lot of concern about perfluorocarbon liquid. In perfluorocarbon liquid, the purity make difference, and impurity make toxicity, makes acute toxicity. The problem are mainly related to reactive and underfluorinated impurity that we really can call impurity. And again, Joaquin Drest published a very nice paper looking at the H value, UV active substance, A1-HPFO. I will not speak about this paper. I want to just draw your attention to the fact that the risk of not knowing perfluoroctane analytic data is higher than not knowing something about the decaline. This is because of 1-HPFO. So we need to be really careful using octane more than decaline. Now, no impurity means no side effect. This is the question. So the point that we don't know all the potential impurity present in very reactive compound. And we don't know all the potential interaction with the other impurity, with biological tissue and with packaging. Pasteur published the assessment of impurity, and they found, still in that paper, 5 different main products identified to be toxic in octane. And also, Metz published a nice paper where he found that octane potential acute toxicity is mainly due to the reactive underfluorinated compounds and degradation product. So that means that we know now a little bit more about what we have to be concerned about. And then in this nice paper, Metz also found the H value as parameter of octane safety assessment. So it means if we have a high H value, we have cytotoxicity, we have adverse events. But the problem is that are these impurities cytotoxic, and is the H value enough to assess the cytotoxicity? And also, do we know all the cytotoxicity, impurity, and degradation interaction product? So what we did, first of all, we validated the cytotoxicity test in this paper. So like a recipe to assess the cytotoxicity. So with direct contact cytotoxicity test using ARC-19 and covering 59% of the cell surface area for 24 hours. And then we also did a dose response assessment of cytotoxicity of PFO contaminants to have a threshold where of ppm where are the cytotoxicity limit of each one. And as you can see, some of them have a limit very, very low, also at 1 ppm. We also found that sometimes H value cannot be enough, because in this study we demonstrate any correlation between the H content and bitter cytotoxicity, because as you can see in perfluorooctane acid, also with very low content of H content, was still cytotoxic, and this other one that had very high H content was not cytotoxic. So probably we need to do a little bit more if we want to have the complete picture. So do we know all the cytotoxicity, impurity, and degradation interaction product? Probably not, because we are always thinking about the single compound, the safety of the single compound, not about the interaction between them. So the interaction between the compound that we are using probably can be iatrogenic as underestimated. Many years ago, we published a paper that after in vivo, after doing our vitrectomy using Decaline, and after fluid air exchange, if you leave under air for a while, at the end you have a small amount of liquid on optic nerve. And despite inaccurate removal, you still leave perfluorocarbon liquid, because we analyzed that liquid and had the spike of Decaline that we were using. So it means we leave perfluorocarbon liquid, even if we try to remove all of that. And adding in another paper, we published that adding heavy silicone oil, you can have this hyperviscous sticky solution that we call then sticky oil. So the interaction that we know right now are regarding the sticky oil. But then we are using triamcinolone, blue, we are using octane, silicone oil in the same surgery. So this paper is under submission, and in this paper we want to analyze downstream all the toxicity given by different interaction. So different harm. In one of these, we were doing surgery, leaving some residual of compounds that we were using. In another group, we were trying to remove all of them, so with the minimal residues. And at the end, we found that if we not remove very well all the compounds, the interaction can be synergistic and can induce cytotoxic effect. And as you can see here, we are a variability less than 70%, it's about 30%. So is cytotoxic. So we couldn't use, all these products together because are cytotoxic according to the ISO. So the purity of single compound is very important, but is not the only risk factor. And then we need to also to remember, and I'm finishing, that we have also biosurfactants. So are the protein induced by the surgery, by the disease itself. It's not just a matter of surfactants of the compounds, but also the biosurfactants produced by our surgery. Thank you very much.
Thank you very much, Mario, for your very nice presentation and also your very nice paper. So I don't know if we have some questions from the audience, don't hesitate to.
We have also the poll, if you like. We have also the poll, otherwise we can go for.
Okay. Yes, we have the poll. Let's go for the poll.
So the presence of low molecular weight component in silicone oil is responsible for cytotoxicity of the compound, modification of interfacial tension, therefore of emulsion potential, temperature increase, all of the above. And if you like, I can read also the second one. The perfluorocarbon liquid may contain impurities capable of creating irreversible ocular cytotoxicity effect, can be left in the eye for a medium to long term, have a density lower than water, all of the above. Okay, if you like, we can start discussion, then we will wait for the answer. Vote? You are on mute. Okay.
Yes, yes, sorry.
Okay.
Yes, of course. So we just wait just a few minutes for everybody to answer. So first, I would like to congratulate you your work on this silicon oil, and also your paper raised some concern regarding this presence of low molecular weight components. So maybe if you want to comment on the result of the poll, and then we can.
The results of the poll are exactly where we're looking. So for the first one, mainly is a modification of interfacial tension and potential emulsion are not cytotoxic in the acute, but the low molecular weight component can change interfacial tension. And regarding the perfluorocarbon liquid may contain impurities. So the first one where 80% were answering as correct.
Thank you, Mario. So I have a question regarding this low molecular weight components. So you've shown that maybe there is no cytotoxicity. So, but however, some cases of visual loss have been described with silicon oil or just right after silicon oil removal. And some maybe damage on of the ganglion cells on SD OCT has been shown. So what do you think about this kind of silicon oil toxicity, and regarding the mechanism? Is it maybe a direct or indirect damage?
So what they think, still we are dealing with a compound that is lipophilic. So means that we don't have to think only about the acute toxicity, but can go really inside tissue. And we have already picture and paper published about the hyperreflectivity inside the retina, or goblets, okay, inside the inner plexiform layer, microcystic edema in inner nuclear layer, and seems to be related to the silicon oil itself. We need to think about the emulsion as a matter of microns and can migrate. And we have also publication about the silicon oil migration to the optic nerve. Probably we are always thinking about, vision loss that is like catastrophic vision loss, but I think that the damage is underestimated. Sometimes we have this kind of material that can induce inflammation, activation of microglia. So I think that still we need to use a compound with very low concentration, low molecular weight component, at least to minimize, this effect. But I believe that we are now having more attention to this phenomenon that is present.
Thank you, Mario. We have also one question regarding the role of the increase in IOP in that kind of toxicity with silicon oil in long term. So maybe the change in the IOP during the silicon oil injection or removal maybe can be discussed in that kind of toxicity. What do you think?
So if we are speaking about the toxicity, not really a toxicity, but if we are speaking about emulsion, we are speaking about the open angle glaucoma. And this is one of, so we are speaking, the problem is still the same. If we have emulsion of migration in the tissue, we can have inflammation, activation of inflammatory reaction. So the point is always to minimize the migration of lipophilic compound in the ocular tissue. And so how can we minimize? I mean, of course, using the silicon oil as less as we can. If we can use silicon oil better than heavy silicon oil, because alkane semifluorinate inside can induce more inflammation. And we know also, we have clinical data that heavy silicon oil, at least at the beginning, increase the inflammation, increase the IOP because of the inflammation. And I don't have clear evidence, but probably also using compounds with low molecular weights can help.
Thank you very much, Mario. I think maybe we need to move to the next presentation because time is running. So I would like to introduce Professor Stelmans for the next topic. You all very known as the very well-known vitreoretinal surgeon. And we are very pleased to have this presentation regarding the cause of toxic reaction after surgery that are not related to toxicity of silicone oil or PFCL.
Thank you, Audrey, for this nice introduction, and thank you for inviting me to this symposium. Indeed, we have seen and we know all, I think, how everything we use in the eye, such as silicone oil and PFCL, or vital dyes can cause damage. But we have a series of patients which were still unclear of how the toxic effect was created in the eye. So in 2017, we were struck that in 2 weeks' time, we had 3 patients in our hospital that all underwent vitrectomy surgery and that they all ended up with a blind eye after the surgery. What I'm showing here to you is an overview of these 3 cases. And you see that the surgeries were done for different indications. 1 was for floaters and 2 were for oil removal. And if you look on the right side of the slide, you see that different tamponades were used, and also triamcinolone was used intraocularly in only 1 eye. Perfluorocarbon was only used in 1 eye. Membrane Bradule was only used in 1 eye. And only 1 eye was filled with silicone oil. All these 3 patients presented with postoperative pain already the day after the surgery. 2 had a corneal erosion, and 2 showed periocular anesthesia. Now I will show you some pictures of these striking cases. This was patient number 1, and the effect that you see is what I call a dead eye. So you see complete atrophy of the choroid and the retinal vessels. There is no inflammation visible. The eye is in that bad shape that it cannot even create a inflammatory reaction anymore. If you look, this is the fundus of the same eye. This is the second patient. You see a very similar OCT image, quite atrophic retina as well. And this is the third case. Again, there's only a very small amount of retina which is there. It's quite thin, and also the choroid has been extensively touched by something that we don't know of. So we saw in all these 3 patients no sign of inflammation. 1 patient developed sterile endophthalmitis on day 3. We saw no hemorrhages. They all had no light perception already the day after the surgery. There was no sign of a central retinal artery occlusion. We saw extreme atrophy, let's call it necrosis of the neural retina, atrophy of the RPE, and a closure of the whole capillary network, and also iris atrophy. Now, we of course were looking for similarities between these 3 cases to figure out what has happened. And first, we noticed that in all 3 cases, we injected an antibiotic and triamcinolone around the eye, parabulbar, at the end of the surgery. So we wondered, is it possible that because of the stuff that we injected around the optic nerve, that this atrophy could occur? But if we look at the way how the retina was affected, we could not think that something blocking the optic nerve would cause such extensive atrophy of all the structures inside of the eye. We also did MRI imaging of the optic nerves of these patients. There was no damage visible on the optic nerve like from the parabulbar injection. So we ruled out that cause being the source of this damage. Another thing that all 3 eyes had in common is, of course, they underwent vitrectomy, so they had been infused with BSS+. Again, PFCL was only used in 1 eye, silicone oil was only used in 1 eye, so that could not be the same reason for all these 3 eyes being hurt so badly. So we thought, well, maybe something was in the infusion. that we used and that caused this damage. So we've been thinking what source could cause this problem. And first we thought of any liquid that was present in the operating theater that could get somehow in the eye and cause this damage. So we're thinking it did somehow by a wrong manipulation, alcohol end up in the eye, or were the remnants of the gas sterilization in infusion tubing. Now, let me explain this. Alcohol, well, I don't explain what alcohol is, of course. The remnants of the gas sterilization, apparently, when the disposables are sterilized using ethylene oxide, and there is still too much humidity when the procedure is done of the sterilization, ethylene glycol and ethylene chlorohydrin can be left inside of these tubings. And we calculated that if 1 droplet of these products would be in the tubing and it mixed with about 5 milliliters eye volume, that we had a 1% concentration of these very, very, very toxic substances inside of the eye. So to answer the question, if any of these solutions could be the cause of the damage, we did some animal testing. And so we did a 3-port plus lana vitrectomy on domestic pigs. And we infused during the vitrectomy the eye with BSS containing 70% alcohol. So we added 20 milliliters in the bottle. And the 2 other pigs were vitrectomized while adding 1% of ethylene glycol or ethylene chlorohydrin into this bottle. 1% may not seem a lot, but I was even forbidden to transport ethylene glycol and ethylene chlorohydrin undiluted in my car, because if the bottle would break, I would instantly die into the car. So it's extremely toxic stuff, and 1% is already a very, very high dosage. So after 1 week, the animals were sacrificed. We took retinal photographs, OCT, enucleated the eye, and we examined these eyes that were operated. And unfortunately, we found nothing out of the usual. So we saw no sign of atrophy, no closure of retinal vessels, and normal thickness on OCT. So then we thought, well, it's somehow something added into the infusion bottle, which is not supposed to be present in the operating theater. And we made just a list together with our pharmacist of the hospital. What kind of products do you think could cause such toxic effects? And they're listed here: phenol, HCl, sodium hydroxide, acetone, or citrimidine. Now, if we had to test all of these drugs on pigs, it was a little bit time consuming and very expensive. So we did it in a different way. We injected these substances in the eyes of pigmented adult rabbits. And we waited for 1 hour, after which the eyes were enucleated and we examined them pathologically. So I will go quickly over this. We did different dosages, dilutions from 1 on 1,000 to 1 on 1. And with phenol, we found actually nothing. So even with pure phenol in the eye, for half an hour, we could not see too much happening. This sodium hydroxide at lower dosages did not cause any damage either. At high concentrations, we saw visual condensation and flat retinal detachment, but no retinal atrophy. Acetone had no visible effect on the retina. Citrimidine caused at very high concentrations purely a vitreoretinal traction because of vitreal separation, but again, no retinal atrophy. But when we used HCl at higher dosages, we found a very, very similar damage than what we saw in our patients. So we saw loss of retinal layering, retinal atrophy, iris atrophy, and a pale retina. So the conclusion here is that HCl mimics the most of all these substances, the clinical changes that we saw in these patients: retinal atrophy, loss of red reflex, iris atrophy. Of course, these experiments were done on eyes that were non-vitrectomized, so there were still vitreous there. But still, we had, well, some evidence that this strong acid can cause this damage. So we did perform a thorough internal investigation in the hospital. there was no logistical or medical procedure violation. Also, of course, this was reported to the competent authorities in Belgium. They also came for a site inspection. They were very helpful with us, but again, they could find no irregularities. And so we decided, since we found evidence that adding a strong acid to the liquid infusion mimicked the damage that we saw in our 3 patients, we could not rule out sabotage. So we informed the Federal Crime Investigation Unit that potentially a sabotage was the cause of this severe eye damage to 3 patients. And actually it was taken very seriously by the Federal Crime Unit, and they're still investigating this. Now, of course, if you think of how these intraocular liquids are produced, transported to a distribution center, go to a hospital pharmacy, to an OR storage, and then being prepared for usage, it's of course very difficult to rule out or to find out where in this chain some sabotage could have occurred. So we don't know the answer yet. The investigation is still ongoing, and I hope that in time we may find an answer what actually happened there. But again, the message of this presentation is that not all toxicity has to be related to drugs or dyes or silicone oil or PFCL that we use inside of the eye. So thank you for listening to my presentation, and I have now the poll. And I'm of course very curious if after vitrectomy you have never experienced any case of unexplained visual loss, or that you have experienced at least one case of unexplained visual loss, which was probably caused by the toxicity from PFCL, silicone oil, or a dye that was used. Or did you experience at least one case of unexplained visual loss, such as I shown you, which could not be explained by any of the above?
Well, let's see, this will be very interesting. And while we have the answers of the audience dripping in, we might start the Q&A. Now, I think I've been there during the first meeting in Sampo, the Netherlands, when you presented those 3 cases. And it's still a very rattling story as a surgeon, seeing that myself, because this is nothing that I don't want to happen to anyone. Unfortunately, it happened to you. Now, the question is, well, first of all, compliment. I think the way that you and your team handled this, just by doing all the sets of experiments and looking where this leads to, this is a good example that really everyone should do if they have a severe case. Just not say, oh well, this happened, it might happen, but really go the extra mile and look at every step in the way. I think I know this is you're a very exact person, but you've really outrun yourself there, looking at every step there. And let's see at the audience. Interesting. I've never experienced any case. I mean, it's probably 1/3, 1/3, 1/3. But
I'm actually surprised that 1/3 experienced a similar thing, because I haven't seen this presented a lot of times, such things. What
we should do is that all the time that this is presented, that somebody from the audience comes up and shares pictures. After the last meetings, I don't even know, I haven't even received emails from Greece, for example. So if you have that, you might as well inform Peter or me. We're really interested in collecting those cases. I mean, Peter is the expert at that. Now, the very important question is, Peter, is there, after all this aftermath, is there anything that you changed in your everyday practice now, being that back to normal, that is still there?
Yes, since then we've done I think 8,000 surgeries without any problem. Now, of course, some things that we changed, yes. We did use quite some things off label. For example, we in the bottle of BSS, we added atropine and gentamicin, for example, which is of course off label. And now we discontinued that because we immediately thought that a manipulation error could be in order. So we omitted that. And we're still doing that. So we don't do any we try to avoid off-label medications as much as possible, and also we try to reduce the amount of manipulations that you have to do to products mainly that you use intraocular in order to avoid contamination that you don't want to happen.
Yeah, I think this is a very good point, because
also what we do is now every infusion bottle that we use is labeled with the patient name and is kept till the next day. And is only disposed 48 hours later. So if ever we see another patient on day one, we will retrieve that bottle that was used, because that did not happen here, of course.
Yeah, all right, that's quite understand. I think that regarding this off-label stuff, it always makes me think, because there is a lot of things that you use off-label in vitreoretinal cases. Now, another question from the audience is possibility of subconjunctival antibiotics. Were those cases sutureless?
Well, we thought of that, but can you really believe that such damage to the eye can be caused just by injecting an antibiotic around the eye? I hardly think so.
No,
I mean, this is something that damaged the eye from the inside. That's quite obvious.
Yeah, they're probably talking about how. I'm always saying that this must be HCl, because the changes do look similar, and HCl is something. If you look into a psychopath mind, of course, this is something that you would use. Because you don't have the level of sophistication to take something else, and HCl is something that you really have. Now, something interesting for the audience there, were there any legal problems for the hospital or the team, or any members of the team following those incidents, for especially,
again, all procedures were checked. Both by our internal safety committee as well as by the competent authorities, and we actually got feedback that they really couldn't find anything that should be done differently, except for the things that we already changed, like reducing this amount of manipulations and keeping the bottles 48 hours. Were there, of course, the 3 patients went to court because severe eye damage happened to their eye, but that's of course covered by the hospital insurance. That's not, I mean, that's something straightforward. And of course, the federal crime unit interviewed all personnel that was present in the operating theater on those days.
Yeah.
That makes sense, of course. That's their job.
All right. Yeah. Thanks a lot. Thanks for this insight. I think it's very important that we share. That we all also share the cases that did not work out as well. Even I know in larger conference you have a tendency to show only what best worked out for you, and not the rest.
Well, now, remember that these cases happened not all on the same day, but 2 weeks in between. So I first had one case, and you know, if you have one case, you can live with it and you don't ask too much questions. It's only because we had the 2 further cases that it rang a bell that, hey, something is wrong here. And I think that's the reason that 34% is saying, yes, I've seen this before, but it was only one case. But if 34% of the audience, which were more than 100 now, has seen a case, that's already 34 cases.
Yeah. All right. And then one question from the audience is, if you examined the intravitreal fluids, that's an obvious no, because they were all in the bin, in the waste bin, and there were no possibility there. But if it happens now in Leuven, it will be possible, and we will be a bit smarter in the end.
Yeah.
So Peter, thanks a lot. Now, what's important, if you look at those incidents and about the incidents regarding PFCL in 2017, there's really 2 ways of doing this. You can say, oh, this happens, and trying to point with your finger at each other, and this is usually industry and doctors. Or you can really get together and try to solve something and make something better in the future. Now, this happened on the level of the hospital with Peter, where they did an excellent workup, but also in Uretin and EVCR, we had vivid discussions about that after the shouting and pointing fingers. And I'm really glad that we have the key figure who actually took that, translated that into a productive part, and this is Dr. Dresp. He's the head of the ISIS 16672 committee, and during the last international call, he was awarded the Achievement Award, because what he did was actually taking those problems that we have and trying to improve the security standards and make a better version out of this ISO 16672 for that in order to secure a future and prevent those things from happening. So Dr. Gress, congrats again on receiving the Well-Deserved Achievement Award, and I'm really looking forward to having your hearing your presentation.
Thank you very much for the introduction. So I would like to talk a little bit about ISO 16672, the current version, and about benchmarking ocular endotamponates, how regulation is changing to help surgeons. Just to introduce myself, I am the ex-senior director for global vitreoretina R&D for Bausch and Lomb surgery for 10 years. Now I'm working as a scientific consultant in ophthalmology and quality management. As Kai pointed out already, I'm head of the technical committee intraocular medical devices of the German standardization organization DIN, and I'm project leader for the ocular endotamponade standard in ISO. Let's first talk about the standard itself. As I said, it's a relevant standard for ocular endotamponates, but we have to keep in mind that a standard does not provide a rigid set of test methods, and it does not set pass or fail criteria. This could result in false sense of security in the general use. This standard shows that specific tests and criteria have to be established by experts in the product and or in the area of application of medical devices. We have to keep in mind that a standard is intended for use by professionals appropriately qualified by training and experience, which are able to interpret its requirements and judge the outcome of the evaluation for a medical device. Standards are developed to be used during product design and development, not for routine testing on batches. Routine tests for testing the safety of medical devices have to be adopted for the device in question, and they have to be validated unless they are tests described in a pharmacopoeia. Validation is a documented proof that a process or a system meets previously specified requirements, the so-called acceptance criteria, in practical use reproducibly. Safety is often tested by using cytotoxicity tests according to the ISO 10993 series. As long as the hydrophobic nature of the ocular endotamponade is acknowledged, any tests according to ISO 10993 validated on the system can be used. The current version of 16672 cites two proposals for cytotoxicity tests, a direct as well as an indirect method. The actual cause of cytotoxicity is not identified in these tests, but must be known and controlled. In this connection, three questions must be answered. What contaminants may be present? What is their risk potential? And what must be done to reduce the risk potential to the utmost extent? Let's now come to the benchmarking. With 34 samples of 12 brands of silicone oils were tested. As a purity parameter for the silicone oil itself, the oligosiloxane content and polydispersity were determined. And to test the integrity of primary packaging components, UV active substances were measured. There were significant differences in the impurity profiles. The oligosiloxane content varied from less than 1 up to nearly 500 ppm. The polydispersity varied from 1.6 to 3.0, and the UV active substances range was from 0.2 to 3.8 arbitrary units. For the PFCLs, 21 samples of 8 brands of perfluorooctane and 25 samples of 13 brands of perfluorodecaline were tested. The tests were gas chromatography coupled with mass spectroscopy to measure the content of the main product. The H value was determined, which shows the amount of reactive and underfluorinated impurities that trigger acute and latent toxic effects. For the integrity of primary packaging components, once again, UV active substances were measured. And in the case of perfluorooctane, 1H-PFO was determined. This is a substance that modifies significantly the surface characteristics of PFO. The H values for PFO varied from below 10 to more than 1200 ppm. The UV absorption range was from 0.1 to 3 arbitrary units, and the 1H PFO concentration varied from less than 1 to 376 ppm. For the perfluorodecaline, the H values were between below 10 up to 70 ppm, and the UV absorption was between 0 arbitrary units and 3.2. Let me give you some comments on the H value. The H value is no sufficient condition for PFCL safety. It is a necessity condition for PFCL safety that no toxic impurities or impurities that can react to form toxic substances originating in the technical synthesis of the PFCL are present. This must be followed by the risk assessment of possible impurities, which justifies the exposed relevance of this parameter. So the quality characteristics vary significantly, not only among different brands, but also among batches of the same manufacturer. You can read these data in the publication listed below. One have to keep in mind that pure perfluorocarbon liquids are not cytotoxic per se. Therefore, cytotoxic measurement as a batch release parameter is not necessary from a scientific point of view and ultimately only serves marketing purposes. In the medical device and pharmaceutical industries, it is very important that in addition to final testing and compliance of products, it is also assured that the manufacturing process will consistently produce the expected results. The quality characteristics of the oculoendotambonades vary significantly, not only among the brands, but also among the batches of some manufacturers. And this is the most important and most dangerous situation. Manufacturers should communicate the purity and quality characteristics of their products in an understandable and clear manner. This involves providing a complete certificate of analysis with special focus on quality characteristics to enable the vitreoretinal surgeon to differentiate between the effects of the silicone oil and the PFC itself and those of impurities. So what has been changed in the current version of the standard? It has been added that the manufacturer shall provide a description of each of the components in the finished product and their respective quality specification and concentrations. Chemical changes during transport and storage shall be considered. Perfluorocarbon liquids may contain oxygen-containing compounds and incompletely fluorinated contaminants, including HF. Specifically, incompletely fluorinated contaminants, including HF, are likely to occur, and they bear a high risk for the patient already at the ppm level. Therefore, the concentrations of incompletely fluorinated contaminants, including HF, shall be as low as possible. Another addition was that different methods can be used for which the specific limits need to be specified based on the risk analysis. In Annex C, a method is described for which a level of 10 ppm has been published to assure material safety in regards of the aforementioned impurities. For any liquid alkaline tamponade, control over synthesis of the tamponade material according to applicable standards and monographs, and analytically controlled purification procedures according to applicable standards or monographs are minimum requirements. So ISO 16672 in its current version provides all the information and requirements necessary according to the current state of science and technology to achieve safe alkaline tamponates. Specific tests and criteria have to be established by experts in the product and or in the area of application of the medical devices. Thank you very much for your attendance. So just the poll has been drawn up.
So thank you very much, Rakim. That was a great talk, very interesting, and we'll got several questions I want to ask you when we've done the poll, which hopefully everybody's doing at the moment. We'll just wait till that finishes before we start. Can we get the results of the poll now?
Just a few more seconds.
Okay. Perhaps while we're waiting, because it looks like it's going to be a little while. Oh, here we go. We've got the results now. Perhaps can we have your reaction to the poll results, Joachim?
Yeah.
So there's the first question is there's a fairly mixed bag of people that have said a law, a guideline, or a direction. But I guess I think what came across in your talk was that the guideline aspect was quite interesting. I thought it was much more rigidly adhere. I thought it was much more of a sort of a strict interpretation that people had to do. So
yeah, the situation is if you follow the standard, the notified bodies and the authorities assume that you have done everything that is necessary. But this is not really the case. Even in other situations, working with standards, you can always do other things than just follow the standard, but you have to justify why you don't follow the standard. And therefore, there's a lot of different things how people regard standards and how they use them.
Yeah. No, and then the last one was the other question was on which tamponades have had benchmarks recently published, and so a lot of people have read your
obviously
papers, which is good. Which is good. If we can remove the poll results now, that'd be great. Oh, let's push that way. Do you think are the new ISO standards? Do you think they go far enough? Do you think could they go further, or should they go further?
I think the standard should not go further because there are so many things that are unique and special to the different types of endotamponates. As I said, I think twice in my presentation, the manufacturer have to be experts, and they have to hire experts which know from a chemical standpoint as well as from a usability standpoint what these products are for. And if just a marketing company tries to purify by distillation or something else a product and brings it on the market, this is far beyond acceptable behavior.
So I guess what struck me about your papers was the huge variability. Obviously, this was before the ISO standards were published, but the huge variability not only between manufacturers but between batches. Could you make a case for policing this? Could you make a case for actually having a regulatory body who actually tests the products to ensure that they're actually compliant with some sort of standards that we set?
I think the problem is that the regulatory authorities don't have the knowledge and the capacity to do these tests. You have to rely on sound and good companies and good manufacturers.
Can I say something? I mean, from the clinical point of view, we had the ISO even before we had the problem with the product from Alamedics. Okay, and the ISO was already there, but it was not clear which kind of method we need to use to assess the toxicity. Okay, and it was using this extract method. So you think that can happen again? This is the point.
If people don't really analyze let's do it the reverse way. The basic is a sound risk analysis. This is the absolute basic. And if the risk analysis is not complete, then it may happen again. Let it phrase it that way.
But as clinicians, we don't know really if that product has been tested, has been an assessment with the risk analysis, risk assessment, very strict. So we just have an NSE approval and we are happy. And so this is the point. Probably on the label, we should see something. I know H value is one of them, but probably, I mean, we need to really have more, idea on the product, on toxicity, because our concern is just it can happen again.
Yeah, for me, the worst thing when I analyzed these results was not that there's a difference between the companies, but that in some companies there is this big difference between their batches. That means they don't have their manufacturing under control.
This is even worse because
this is the worst thing. This is really the worst thing.
It makes it incredibly hard to interpret how we, because I mean, for years there's been a folklore that certain types of oil emulsify more than other types, partly based on viscosity and partly based on clear physical properties. But if they're all different by batch, of course, we can't draw conclusions and we can't learn and we can't take our science forwards. So it is a big problem.
Can I ask a question on that topic? I mean, I've often found batch differences quite alarming. Do we then expect companies to be able to give us individual data on each vial that we use? How far do we drill this down? I've often wondered about that. And do batch quantities differ? Do some companies' batches involve 700 vials and other batches are 10 vials?
I think one problem is that some people try to establish toxicity testing on a batch basis. Yeah, I think this is the wrong approach. The right approach would be to have validated manufacturing procedures and to do a parametric release. That means you test the conditions under which you have validated before, and if the process has met all these conditions, then nothing will happen. The problem is if you try to test quality into the product. This is always a problem.
Yeah, I think this is a very valid point, and this also relates to, do we need authorities to test that? The more tests that we have from authorities, the more exact we write the cookbook of what some terrible company has to do to pass this. But what we want to is a very responsible company that has knowledge with a solid manufacturing process.
Yeah.
And this is what it all comes down to. Therefore, the ISO standard is a horizontal standard. You have to jump across this to reach this, and afterwards it's up to your responsibility. And it's for all of the surgeons, I would advise you just to go to some manufacturers and have a word with them. You can tell within the first 5 minutes if you will be using their silicone oils or PFCLs in the future. That's for sure.
But the horizontal standard is a 10993, but the 16672 is a vertical standard.
Oh yeah.
Yes,
Okay, well,
go on. Sorry, yeah, fine.
no, I wanted to go with the closing remarks. So please go ahead, David.
No, that's great. I was gonna, but I think no, I know we're running short on time, so that's great. Thank you very much. I'll let you finish off. Thank you.
All right. Thanks to the audience. Thanks to all the speakers, especially in your free time that you've taken off your families and your loved ones to be with us on this very important topic. Thanks to EVCR and DORC for organizing everything, and thanks for the panel, David and Aude, for putting this together. James, Cecilia, and Danielle on the EVCR part. This has been a really, really helpful session for all the audience. Please do complete the evaluation form, as you will need that for the CME points. And with that, I wish to say that probably we're on a very good road regarding safety of the products. I think it's a very long road, and we will be seeing each other again. And with that, I'm saying buona noche, good night, buona sera, bon nuit, if I forgot something, and auf Wiedersehen.
Thank you, everyone.
Thank you, Kai. Thank you, everyone. Good night.
Thank you.